Dr. Frame was highly complimentary of Dr. Troutman and his ability to share some wonderful information with you and helping you to learn things that you need so that you can get out of here and be functioning entry-level AEMTs and paramedics. So that having been said, Dr. Troutman, it looks like he's got a wonderful topic here tonight. I'm kind of interested in this one, EMS best practices or something like that. So I'm going to turn this over to you, sir. And remember, folks, this is being recorded, so be careful what you say or how you say it.
All right, thank you so much for that introduction. I did lose my chat bar when I started sharing, but hopefully we can figure that out. Anyway, so this talk that I'm going to give tonight, this was actually one I gave at a conference a couple years back, so I kind of went through and updated that. As you can see, kind of EMS best practices or something like that. So I'm going to cover several of the, I guess you could say, hot topics in EMS and some of the science behind them and what have you. And please, if anyone has any questions or anything, just pipe up. Don't feel like you can't talk over me. I consider this pretty informal at the end of the day. Paid disclosures, I'm always looking for more pay. That's great. So I actually wanted to try to do this as a Jeopardy form, but that is just so hard to make the PowerPoint cooperate. And I'm not sure exactly how it would work trying to do it over Zoom meeting. So I kind of gave up on that. So it's going to be a little more traditional, but these are going to be some of the things that we will try to hit upon. So I always like to show this map whenever I lecture at various places. Because certainly, and I don't know if everyone here is Texan or I know everyone, we have kind of a diverse group from potentially across the US, but I just like to point out where we are in our great state of Texas. And many times we get lost in Dallas, Fort Worth, Austin, San Antonio, and Houston, but we really cover this very vast area out here in what we call the Panhandle or West Texas or the South Plains. I don't really do much out in El Paso. That's truly West Texas, and we've had debates with some El Pasoans about really what is West Texas. But our focus is this area that's circled. This is generally where I work and help with our EMS systems in this area and work clinically. And in this area, we do have well over 1 million people, and we have a lot of real estate, as you can see. So that sometimes brings in some unique pieces to our EMS practice. Because we not only have our largest cities of Lubbock and Amarillo, which are several hundreds of thousands of people, but then we do have various parts of this area that literally run dozens of miles without another person and potentially one ambulance covering 100 square miles or more. So that creates conundrum sometimes for us in EMS. So first thing we're going to talk about is the Krebs cycle. Actually, I'm completely kidding. We're not going to talk about the Krebs cycle at all. But I love showing this slide and kind of get everybody worried that we're fixing to have a really boring talk. So let's talk about cardiac arrest. And I know hopefully many of y'all have already participated in some cardiac arrest, but I want to really talk about what really matters and what real difference we can make in EMS. And what has really appealed to me about pre-hospital medicine is what we do in patients' rooms, what we can do in the aisle at Walmart. We can ultimately change the outcome of patient care. On the flip side, if we go back 30 years ago, all EMS did or was a transport agency to get a patient from point A to the hospital where the actual care could occur. But now we found out is now we are a specialty of the House of Medicine because we have literature that supports what we do pre-hospital that can change patient outcomes. So that's really huge and something all of you should be proud of being part of this profession. So first thing on cardiac arrest, we got to stay on scene. 20 to 25 minutes. The science is very clear with that. This is on a medical type arrest and generally adult, but certainly even in pediatric situations. These are also certainly scenes that are relatively safe. We should work these codes 20 to 25 minutes on scene. I also don't care how much you can bench press or how many pull-ups or push-ups you can do. We have the data that shows even the biggest, burliest firemen out there, they cannot do chest compressions very well after 2 to 3 minutes. So no matter how tough you are, we should always be rotating and getting that fresh new set of muscles, that fresh ATP in our bodies to be able to do those compressions, or some places may have the liberty of using a Lucas device or something like that, which that's a whole nother topic point, but I think there is sometimes a place for those. The other big one I'll throw out here that some of you may say, what, is ignore the airway. There has been little scientific evidence to show that managing an airway in cardiac arrest changes outcomes. It doesn't necessarily give ROSC, and it doesn't certainly send grandma and grandpas home to their families, which is our ultimate goal in cardiac arrest. What I'm kind of a big fan of is what we call passive oxygenation. Essentially, we throw a non-rebreather on the patient. Our protocols usually say for at least about 6 minutes. And really the biggest reason what this does, allows us to focus on what really matters in cardiac arrest. Two things: early defibrillation. So it's even great if we can potentially have an AED on scene before you even get to the site, to where we have a standby or AED. But certainly once you get on site with an AED or your monitor, see if the patient needs defib, because these early defib arrests, the longer we wait, the less chance they're going to be able to get ROSC. So early defib. And number two is high quality CPR, good compressions. That means 2 to 2.5 inches of depth with good recoil, and it's 100 to 120 times a minute. It's not more than that. It's not less than that. It's not deeper than that. It's not less than that. So if you're outside of those realms, that is not good quality CPR. So you really have to focus on that. So at the end of the day, really nothing else probably matters in cardiac arrest. I think I'm going to mention epi on one of these next slides. Oh, I'm pushing the wrong keyboard. I got too many keyboards. Actually, we'll get into epi next. So refractory VFib. So this is another one that comes up. If you haven't yet, you will be on a code that, oh, great, this is VFib. Let's shock it and we'll magically get them back to life. And you shock them and guess what? They're still in VFib. And then you shock them again and they're still in VFib. Then you shock them again and they're still in VFib. So one of the things that folks have discussed, and many of us do now in the field, is something we call double sequential external defibrillation. Most of us usually advocate this for after 3 to 5 normal shocks. And essentially what this is doing is utilizing 2 monitors, or it's often a monitor and an AED from potentially a first responder that's on scene, because most of those do have an override mode. And essentially pushing both of these at approximately the same time. You technically can't get it within the millisecond of the same time, but it doesn't have to be. It's just you clear everybody and you push them at the same time. So what this does is you're not only given 2 bouts of electricity, but it's also the 2 different vectors of electricity. And so often what we find with that is usually one of 2 things. We usually get them out of VFib. We either get them back or we put them into asystole, which oftentimes asystole at that point, and we're this far into the code, we may not ultimately get anything back. But we certainly, there's papers out there, and even in my services that I work with, we have patients that we've utilized this on and gotten patients back that I truly feel like if we hadn't done that, we may not have. Okay, so epinephrine. So, okay, we got to give epinephrine every 2 to 5 minutes. Well, I'm going to go on a limb and say, we probably could not give epi at all. I know that AHA advocates for it and says that we should. The study, there was a large study out of Japan that looked at like tens of thousands, not hundreds of thousands of code data. And really the only positive thing that they could find on epi was if you were going to give it, make sure and give it relatively early, that the earlier you gave it was probably better. And there was lots of probablys and ifs in there. I still think at the end of the day, we're not really sure if epi is a really good thing. And even in those situations, we found that often maybe our ROSC rate was a touch higher, but our survivability outside of the hospital was unchanged. So that's something to keep in mind is what is our endpoint. What I like to do, and I modeled this after a few other folks, at least here in Texas, what we do is we certainly push 1 amp epi, after we've gotten our good compression started. We've already analyzed the rhythm, and we usually, I'm fortunate in our bigger cities at least, usually to have at least 6 crew members on scene with our first responders and our transport agency, and somebody can be getting an IV or IO. And once that's established, to push that first epi. After that, we push another amp into a liter bag and we just run it wide open. So again, what does that allow us to do? It allows us to really focus on those two things that matter, to continually to monitor to see if we need to defibrillate, but most importantly, to give really good chest compressions. And then after we kind of get in that 6 minutes or so of routine where we've analyzed the monitor a couple times, hopefully by that time we've already given some epi, then we can start thinking about the airway. And even then, although by protocol, I allow people can choose to either endotracheal intubate or to place, I like the iGel as a supraglottic device. I think it's the best supraglottic device out on the market. But I'll tell you, in cardiac arrest, probably the iGel is best, and probably it's best not to intubate a patient. And the primary reason for that, and we've all done it, we can say, and even with a video device in intubating a patient, well, I can intubate a patient and not have to interrupt chest compressions. But I'll tell you, it's rare that that's the case. Everybody's been there, they're on that chest, the chest is bouncing, they're in with their video device, and they say, no, stop, just a second, and then they place the tube in. Even just that couple seconds of stop, your cerebral perfusion falls profusely, and it may take 30 seconds to a minute more of chest compressions to get you back to where you were. So versus placing an iGel, that can be done blindly. There's never even a consideration of stopping. So generally encourage an iGel over an endotracheal tube once you decide to establish an airway on arrest. Although I'll say there are some agencies that do passive oxygenation until ROSC and then make a decision. Because certainly once you obtain ROSC, patient may be awake enough to not even need intubated. Or maybe at that point you choose to actually do like a delayed sequence intubation or some other BBM or some other management of the airway. So another piece of cardiac arrest is obviously we don't get everyone back. So what do we do with patients after we work them 20 to 25 minutes? We should be terminating on scene, termination and resuscitation. Most high quality agencies will have a protocol for this. This is very well regarded in the literature to be something that is well within the wheelhouse of paramedics. So essentially, yes, paramedics should stop termination. So you actually don't call death. And I even hear folks that have been doing this a long time to say, well, hey doc, we pronounced this one. No, you did not pronounce. Only 2 people can pronounce. And that is a physician and usually like a JP judge type person. It's typically a particular elected type official. Paramedics cannot pronounce death, but you can terminate resuscitation. So you no longer resuscitate, and that patient usually ends up in a medical examiner where that technically is the person that pronounces the death. You do not need necessarily online medical control to do this. There are, I would say, robust protocols to allow this to be done in the field, but they're actually pretty simple. You know, the big things we look for is one, have we established some sort of airway? We've delivered some oxygen. We've gotten an IV or IO. We have given some epi. We've gotten them on the monitor. We've given them 20 to 25 minutes of high quality CPR. And another ones that are a little bit unique is we want to make sure all of our peers that are on scene, so all those providers on scene taking care of this patient who they have a vested interest in this patient's well-being, that all of them are in agreement that, you know what, we've tried everything, we're in agreement to stop. And then the other piece of that is the family. You know, sometimes you're in some sort of social situation where it's just, you don't have a good vibe about stopping where you're at. And so we want to make sure the family's on board with that. And we usually try to assign a chief level type person to discuss with the family during the code. And then as the code progresses, start to build the family up on that, you know, look, we're doing everything we can do at a hospital. We're not having any luck with this. You know, we may think about allowing the death to occur here. And most family will ultimately be okay with that. Certainly when it's an older person or somebody that's somewhat a suspected death, you know, these are obviously a lot harder on pediatric deaths. 6-month-olds and 10-year-olds, they're not supposed to die. So those we do tend to see a lot more transported to the hospital, and I think that's okay to do.
Hey, Dr. Troutman, this is Greg White out of Amarillo.
Yes.
Hey, on the stopping of and calling out the patient, so to speak, in quotations, is that something we need to stop in Amarillo doing the 1079 thing then, to dispatch?
What's 1079?
It's basically you're calling them, you're stating that they're dead, instead of stating that we stopped all efforts for life-saving techniques.
Right. So, I mean, there's a protocol in the protocol book. As long as you meet all that requirements, you're done. You can terminate resuscitation. Now, this is, yeah.
And we don't have to notify dispatch of that, correct? Or we do?
So, I guess, I don't.
Hey, Greg, can you hear me? This is Kathy.
I can. He froze up.
He did.
Purely from a protocol medical standpoint, no, I don't think that dispatch necessarily is notified, but I do think there is sometimes some reasons why dispatch should be notified, because it's a kind of a closure of the call, if you will. Does that make sense?
Yes, sir, it does.
Perfect. And then, the other thing I didn't get into on this, because I thought what you were asking about, but I understand what you're asking now, is just a non-workable patient or a very obvious death. This is a patient that you get on that is rigored or has obviously been dead for days, or is some sort of massive trauma that is, just injuries incompatible with life is what we often say. So, and those patients, obviously, we don't necessarily need to meet all these. Those are different requirements. Just if it's incompatible with life, it's incompatible with life, and you withhold or terminate resuscitation essentially without starting. And usually we do advocate potentially, get some asystole leads from a monitor on that. That's pretty standard. So something else that comes up, which all of y'all are in paramedic school, but AEMT and EMT on codes, I'm also one that's big on what more can we do, and we talked a little bit about our vast area, and should EMT start IOs and give epi. And there actually was a study on that showed that there's really no reason why they can't. At the end of the day, from a procedure-wise standpoint, an IO is a pretty simple procedure. If you can squeeze a trigger of an easy IO gun and palpate around on the leg and understand the handful of contraindications, then they can probably start an IO. And certainly we think about maybe some of these situations where it may be only an EMT that's literally 100 miles from ALS care, which, even by air is going to be, half hour or more. And they may have a 30, 45-minute transport into a hospital. Is it better that EMT learn? We know they can already use the AED. They can already give potentially high quality chest compressions. Maybe we also teach them to do an IO and start an epi infusion, and just place the non-rebreather like we talked about. So that gives us a little different perspective, though, in that resource poor situation. In these situations, you're not going to probably have 6 providers. You're going to be lucky to have 2, and the highest skilled may be just an EMT basic. But at the end of the day, what we talked about, what saves lives and what increases ROSC, is what the EMT basics can do. Ketamine. Oh man, we could talk about ketamine a whole lot. So if you know me, you know that I'm a rather big fan of ketamine. I think it is a great drug for pre-hospital use. It's probably one of the most controversial drugs that we deal with from our emergency physician partners, sometimes fussing about why on earth did your medics give ketamine to this person, yada, yada. And so we deal with those as needed. But ketamine is great for us. It rarely affects hemodynamics, which is huge, and it rarely affects respiratory drive. When we think of medications like Versed, they're probably going to stop breathing if you give too much of that. Even people talk about like Haldol or Geodon for some of these patients that maybe are having psychiatric type breaks or schizophrenic situations. Those take such a long time to really have much of an action. But ketamine is great, certainly for this excited delirium, which I know politically and across the spectrum, people are trying to get away from using that word, because there has been a lot of political connotation with that. Kind of my stance on ketamine has been, we should never be given it just to subdue a suspect or, somebody as far as from a PD type standpoint. We should give it for genuine patient safety and crew safety. So if it's taking, 6 people to control somebody who needs to get in an ambulance and get some medical care, then we document that. And those are the type of patients who should receive a dose of ketamine. Before we did that, what would we do? You'd either put somebody on each extremity and we would have broken ankles and broken wrists. I've seen that a number of times from patients being essentially held down and being carted in, or crews get spit on, spit in the eyes, and certainly some subset of those people are going to transfer communicable diseases and stuff. But if you give ketamine and monitor them, these patients do really well. It keeps our crews safe and what have you. Ketamine can also be used, obviously, for pain control, certainly on extrications. We do actually a lower dose. I think that should actually be 0.2 to 0.3. And I've even advocated giving it over a few minutes in a 50 cc type bag, not necessarily just a slow push. But it's good for, really good for pain control, especially during extrication type situations. CPAP. So I intentionally did not want to bring up COVID in any of this talk because I know that everybody is COVID fatigued, and fortunately we are, I won't say the pandemic is over by no means, but we're certainly, I feel very strongly we're at the tail end of it, and most of us has resumed to relatively what I would call normal pre-hospital care in our communities as far as with COVID goes. But CPAP was put on pause with that a lot, so we're going to more talk about that outside of COVID. So keep in mind, whenever old people get intubated, they die. There's a relatively, I'm looking at chat. Oh, I see some chat. I don't know if I can exit. There it is.
It's okay. I was handling it over here for you.
Oh, okay, gotcha. Yeah, so everything's like flashing here. Okay, got it. Okay,
no worries.
So CPAP. So there's a certain subset of elderly people, or you could almost say all people, but certainly elderly people, when they get intubated, and certainly when they have comorbidities. And who are some of the common people we intubate? They're very obese, they have congestive heart failure, they have COPD, they typically also have hypertension, diabetes, all these various things. And sometimes they do need intubated in the field or need intubated, period. But a subset of those patients are going to go into an ICU and they're going to develop a hospital-acquired pneumonia. And you can see here, over 50% mortality rate for patients intubated over 70 years old. And I even wonder if that's on the low side. I mean, our bodies weren't designed to have tubes down our throat and be put on a machine. It's just not how we function at our best. Sometimes that can be temporizing and really good, but it's also a lot of avenue to develop infections and develop really bad, really deep-seated infections and end up septic and hypotensive and all the other things that come with that. So with that in mind, we've seen EMS, because obviously there's some EMS agencies out there that essentially do not intubate at all. Some probably intubate a whole lot. I think most of us are finding out, it's somewhere in the middle is where we should be. I like to say intubation is probably one of the sexier things that we get to do as far as a skill, because you get to use some really big high-powered drugs. You're essentially, that patient's life is now in your hands. If you cannot successfully establish that airway, they may die. So that is a huge undertaking that we take whenever we give a patient a paralytic. And then hopefully we place the tube, and oftentimes some of the things that they were having problems with will at least momentarily be fixed. Their saturations will come up, their capnography will look better, etc. But what I would urge to you is, in many of these patients, give a trial of CPAP. Certainly if they are somewhat awake and alert, if you're very somnolent or lethargic, obviously that's really about the only contraindication for CPAP. But if they're pretty awake, but their sats are low or what have you, give CPAP a try. I've seen people that have come in looking like they are in death's door from an oxygenation standpoint, and you throw a CPAP on them, and in 15 minutes, you're like, that guy looks like he could go home. So, in one situation, I could have intubated them earlier. Well, now I was able to provide them some relief and save them that intubation and save them that 50% mortality rate. So just something to think about whenever we're thinking about managing airways. CPAP is not as sexy as the intubation, but I'll tell you, it's probably a bigger benefit in many of our patients. Obviously, some people's going to fail to CPAP, some people's going to need intubated. It's still an important skill that we have to know and utilize. Okay, IV fluids. So I'm going to take a drink of my, and if you haven't, I don't know if y'all are seeing me, but if you like Diet Dr. Pepper, I strongly encourage you to try the new zero sugar. It tastes just like the regular Dr. Pepper. It doesn't have that funkiness of the Diet Dr. Pepper. So needless to say, I've been hooked on those. So IV fluids. If we look at what EMS did, 10 years ago, we started like, okay, we're transporting patients, we're starting to do things. Everybody got put on a backboard, everybody got oxygen, everybody got an IV and IV fluids. And now we're at the point, okay, stop all that. We need to let some of our care and the patient dictate on what needs done. And that is certainly true on IV fluids. Not every single patient, that we establish an IV in needs to have fluids going. Let the patient's vital signs dictate that. And it also doesn't mean, well, this bad chest pain, they don't need an IV. No, they probably do need an IV. If they got risk factors and such, they're going to get blood drawn, or hopefully even your pre-hospital system is drawing blood in the field. That can have some controversies, but that's a whole nother topic. But just because you establish an IV doesn't mean you have to give IV fluids. So if a patient is normotensive or even hypertensive, or their heart rate seems to be generally okay, they're awake and alert, they may not need fluids. Certainly a little TKO or something's okay, but we don't need to dump fluids to them. Another big one we have certainly learned on, and certainly our trauma colleagues back us on too, is this idea of permissive hypotension and this washout of coagulation factors in our major trauma patients. It used to be taught that if it's a major trauma patient, we need the two biggest, baddest IVs you can get established and get all the IV fluids you have in the ambulance and give it all in. Just pour it all in. That's how you should treat traumas. No, that is not how we should treat traumas. We should allow a little hypotension. A 90/40 trauma patient that's awake talking to me, but a tractor ran over their torso. Obviously, I'm worried about this patient. I don't think they need a bunch of IV fluids. What they probably need an operating room to fix their huge liver lag. What they don't need is 2 liters of fluid that's going to take their 90 up to 100. It's going to dilute their blood. It's going to push any clots potentially out of their liver that's already formed. And now you have less coagulation factors, and you have higher pressures, and you just bleed out more. So we find that this permissive hypotension idea is okay. I like to put a lot of thought into somebody's mentation during trauma. If they're not mentating right, at some point you got to give fluid, and you do sometimes have to give lots of fluid. Even some agencies are giving universal blood, whole blood in the field, which again, that's a whole nother topic, but I think that is a potential good future of EMS, but there's plagued with some issues with that. And probably the biggest one is blood supply. I know San Antonio gives whole blood in the field, but they've had to really ramp up donations. And we've even talked about, man, if all EMS agencies across our country started giving blood, we would be plumb out of blood in this country. So there's still a lot of things to really get through that. So, but then it starts to make you wonder about manufactured blood, synthetic blood. I know there is some information out there about that, and people's worked on that, but probably within all of our lifetimes, we'll see something like that. Yeah, and it's not been as an issue lately, but I know a few years ago, if you've been around EMS even a few years, we essentially had no IV fluids. We used it all. So that was rather interesting. These are kind of just stuck in here from this lecture, but I like to do a lot of the disaster medical stuff. I'm on the emergency medical task force for Texas, and this was actually set up at Hurricane Harvey down on the Gulf Coast. It was pretty cool to be part of. We were seeing about 100 patients in a mobile medical tent, all kinds of injuries from minor cuts and scrapes to cardiac arrest. Obviously, the more recent thing that EMTF has done is we've taken care of a lot of COVID patients. from the first COVID patients to hit the U.S. in San Antonio. Our EMTF tent was set up in El Paso for a month, and I spent about 3.5 weeks out there taking care of those patients. But even all of you as paramedics can be involved with the Emergency Medical Task Force. So if you're not familiar with that and that's something to you, talk to your home agencies about it, or Google it. And if you're not in the state of Texas, most states have some sort of state-type agencies like this that respond to disasters. And it's actually a really cool thing to be able to get to be part of. I might get stones thrown at me. Air EMS. So I will tell you, I think Air EMS certainly has a place, but I certainly think that it gets overused a fair amount. You know, I think when we talk about those very rural air EMT basic ground crews, there often is a benefit for a paramedic on scene. You know, I think in our much more major cities that have a big availability of paramedic care, you can do 99.9% of the things that helicopter folks can do. And usually the time-wise is not much of a change versus you doing and transporting versus the helicopter transporting. You know, there obviously is a lot of controversy just in general on the helicopter EMS side of things, but there certainly are good opportunities for air EMS, but I certainly think that they sometimes get overused as well. Priority dispatch.
Dr. Troutman.
Yes.
Can we go back to air EMS for a second?
Sure.
Can I play devil's advocate for a minute?
Absolutely.
I think, and I'm sure Ms. Dinsmore will tell you, I speak from personal experience on this, that I think that while air EMS may be overutilized, I think that there are some times when that may be the only viable option for a valid transfer. And you'll have to excuse my 6-year-old bouncing in the background right now.
Are you specifically talking more like 911 scene calls or inter-facility transfers?
I'm talking about interfacility, and I'm specifically talking about certain subsets of patients where it's EMS crews don't see this stuff. And so you need that dedicated presence in order to be able to safely transfer the patient.
So yes, I would absolutely agree, hands down. I mean, I think there are absolutely situations, and if we just talk interfacility transfers, where the helicopter or even a fixed wing in some of those situations is absolutely completely appropriate and is absolutely the best for the patient. You know, it also, to me, it also gets a little sticky on some things of, well, we only have one ALS unit, and if we drive them 2-3 hours, there's nobody to cover these 3 counties. So that plays into it, which, you know, that gets to be a broader discussion, and there's a political piece, there's a money piece of that, and who's paying for what. You know, I don't like it when I see a helicopter get used because, well, you know, the patient had an IV in, so they need an ALS crew, and we didn't want to take the ALS crew out of this county. I don't think that use was best for that patient, but I agree there's a bigger discussion. Well, maybe that was the best use for the next patient. But then also now that helicopter is on that transfer, what about the other patient on the, you know, west side of the town that maybe needed that more specialized crew, like you said? So it gets really complicated. I don't have a very specific answer for any of it. I think that we could do better. I think it needs better coordination between ground and air and the facilities. Oftentimes, not always, but often these are 3 different, almost competing, you know, interests into how the patient's moved. But sometimes those do come together. So it all gets very complicated, and that's why we have a lot of stuff.
I agree with you. Knowing that you're at UMC, knowing that you have a specialty team at UMC that's the only one in about 190 miles, knowing that it's been utilized to transport one of my family members is why I brought that point up.
Yeah.
You are
and
the only dedicated neonatal team in 200 miles.
Absolutely. And I think that's fantastic. And you know, and it's probably 90+% of these are absolutely appropriate. But, you know, I generally think as a specialty, HIMSS, I think we could do better. I don't know. I'm not a medical director for any helicopter service. So I don't have my fingers in that, if you will. And I know there's complications with that. And I've talked to other colleagues and friends who are heavily involved with this. But that tends to be one of the big issues that comes up is it's hard whenever it's not all the same person or thing. If helicopter owns the ground and they're also somehow tied into facilities, I think that can help. I think telehealth potentially, we've seen the telehealth needle move a lot this past year with our pandemic. I think a lot of these transfers could benefit from telehealth, like you say, back to a tertiary care center, back to that neonatal receiving team to say, you know what, I think that actually looks stable enough to go by ground, or, oh my gosh, absolutely, that needs to go by helicopter. And I think they can help triage this a little bit better. I feel like there's more we can do to be better at that. And I think what it ultimately does by being better at it, we allow the helicopter to be more available whenever it's needed, more hone its need. It just, we all see the times when the helicopter just wasn't needed. It didn't make any sense. And how many times when it was doing that, did it miss out on the time it really could have made an impact? But thank you. So priority dispatch, hopefully all of you are at least sort of familiar with this. I think this is something that potentially comes up on the National Registry test. So, the smallest communities, it hopefully you understand how a 911 call tends to work. Almost anytime you call 911 in America, it goes to what's called a PSAP, a primary service access point, which generally is owned, if you will, by the sheriff's department, or usually some sort of a police type entity, because it still kind of felt like that's the most important thing. Even if somebody's having a cardiac arrest, we want to know, if there's somebody running around with a gun or there's some kind of violence occurring, that tends to be kind of the first touch whenever you call 911. But then from there, it's, well, I'm calling because they're not breathing. Then that usually gets disseminated to the healthcare piece or the EMS piece. But that can all depend on your local jurisdiction, your agency. Sometimes the sheriff dispatch may just say, all right, we'll send an ambulance your way. What's the address? All right, they're on their way. Click, and it's done. The most robust system is going to have a priority dispatch type system. And this is where you have a call taker, where I'm going to, obviously, I get sent the call from the primary PSAP, and it's a medical call. I'm going to verify your address and ask what's going on. And we essentially have some priority calls: chest pain, shortness of breath, major trauma, stroke, and I think altered level of consciousness are the 5 big ones. If we hear any of those right off the top, we get assets rolling, usually all the assets that we have available. So usually in a robust system, that'd be our first responder and an ambulance, essentially. And then we ask a series of questions to ultimately end up at what we call a determinant. And these determinants, I think there's like 26, 28 cards. Of course, it's all electronic. Actually, I have one of my manual ones here, just a good reference. But these cards, they just have a number of questions in there, and you end up with a determinant, such as like a 23C6. That may mean we should only send an ambulance without lights and sirens, or maybe we should send an ambulance and a first responder, typically a fire engine or some sort of a first responder vehicle, lights and sirens. And what this is, it's essentially a scientific-based thing, if you will, for dispatching. And the other piece of that is these call takers can also start to give pre-arrival instructions. And we've talked about how EMS can really move the needle, and this is one of the ways that dispatch has really started moving the needle in more recent times. Hands-only CPR. Once the dispatcher confirms somebody is in arrest, they're going to ask the person to do CPR. That's important for even small communities, and in smaller communities, we just have difficulty on the education and training of this. But priority dispatch is certainly considered a standard of care for 911 dispatch currently for pre-hospital care. So psychiatric facilities. So our medics, people in the ambulance, they decide where trauma activations go, where stroke activations go, multiple best patient destinations. Obviously, there's usually a protocol built behind that. One of the kind of newer things, at least I know a few of us have done, is what about psychiatric patients? Should those patients go straight to the ER, or should they go straight to a mental health hospital that maybe is, I hate to say more capable of taking care of them, but certainly more capable of giving them the definitive care that they need? So there are certainly difficulties with this sometimes in your area. The psychiatric facility may just not have interest in taking patients directly from EMS. We have accomplished doing some of this in some of the agencies that I work with. Alcohol use is probably one of the most difficult, because the psychiatric facility, they want a patient that has been medically cleared, and usually that is some low level of alcohol. Although we know you can be a chronic alcoholic and have a level of 300, and you could be talking normally, but you could be a college freshman and barely be the legal limit and be acting stumbling drunk. So that we struggle with. I like to look at it as clinical intoxication. We can all look at somebody and go, that guy's drunk, or, I don't think he is, even though he said he drank earlier. But that often is a sticking point for some of these transfers. That is just a protocol we've utilized for this. So mental health crisis. So essentially, these are patients that have a known psychiatric illness, so they are schizophrenic or depressed, and probably have had some sort of suicidal attempt in the past, or they've been part of the mental health community, if you will, in the past. They have normal vital signs. They are denying that they've taken anything. These patients, they don't tend to lie. If they took a whole bottle of Tylenol, they're going to say, yeah, I took a bottle of Tylenol, I wanted to kill myself. They don't tend to lie about these things. They are now touching the system because they do genuinely want help. So we ask them, have you actually done anything? Have you taken anything? And then obviously no signs of trauma. If they have just a little scratch on their arm or they tried to cut themselves, that may be okay. But if it's something that needs sutured or something, those probably need to go to the emergency department. But if they meet all this criteria, then essentially these patients are best to go straight to a mental health hospital, where they have mental health professionals, where they can get them medications that they need, start any kind of psychotherapy and what have you. Versus what happens when they go to the ER. We always have those 2 or 3 rooms right in front of the nurse's station, which is where all the action is, and that's where the psych patients go. We tend to have cameras in there and things on sticks looking at them, and people all around them. These are not good environments for patients with mental health problems, and we do them a disservice, and we draw blood that's probably not needed. It takes us hours to get it back, and then we have to arrange transfer. They spend 4, 5, 6, 8+ hours in a facility, and they're really not getting the care they need. So mental health is a big part of what we do. It even affects our crews and us all personally sometimes too. So we want to figure out how can we care best for these patients. And I'm a very big advocate of these patients being taken straight to a mental health facility where they can get the best care possible. I want to cover that. Another question is, should EMS be transporting them, or should police transport them? We do have some kind of mental health crisis team that are formed out of police departments. So I think that's actually probably the best option, is for EMS to come on scene, essentially take some vital signs to clear them medically, although that gets a little sticky because typically that's not what EMS does, and doesn't tend to be what I do in any of my services currently. But certainly in the future, I think we can see that, and then essentially pass them to like a mental health crisis team with PD that can then take them to a facility. This was actually a wreck recently. This was right near my house. We heard a boom, and we thought, what was that? We thought somebody was shooting cans or something, and then we saw a bunch of smoke, and it was actually obviously a pretty significant wreck where a dump truck was steel, and this tractor trailer just ran in the back of them. Shockingly, there's almost nobody was hurt. I think the guy on the tractor trailer had ended up having like a broken distal tibia or something. But that was interesting to be on scene that quick, because we were out there just as they cut the guy out. The truck was on fire. But I know this is what y'all live every single day. All right, I think we just have maybe a few more minutes, but I want to just mention about stroke. You know, I'm a big fan of using the Cincinnati stroke scale and then also considering using the VAN score. Even the smallest of hospitals that may not administer TPA, although I would argue most even small rural hospitals have some sort of tele-stroke situation where they often can administer TPA, but we should be activating a stroke from the field just like we should activate a STEMI from the field or trauma from the field. And the biggest thing that this really allows us to do, sometimes CT scanners need warmed up, or they, you know, maybe we had a abdominal pain patient that we could wait a few minutes and not tie up the scanner, but essentially make this patient a high priority for the department as we roll in. You know, we've pushed the limits on when we give TPA, you know, 3, 4, 6 hours. You know, some people even advocate that for being longer than that. Certainly doing the large vessel occlusion retrievals is kind of a newer thing. We don't have a lot of those skilled people across the U.S., but we do occasionally have some in our areas that can do these. And usually the VAN scale is more or less used to go from just a typical stroke to somebody that more has a large vessel occlusion. All right, I think we'll talk about backboards and we'll stop. So, and I understand, I think that we have stopped teaching how to backboard people too specifically with the National Registry stuff. Hopefully you're not routinely backboarding people. If you are, please stop. You know, backboards are best for extrication devices. Around here, we have cotton fields that people like to run off the road and run 150 feet out in the middle of the cotton field and roll their car several times, and we can't get the ambulance to it. Put those patients on the backboard, walk them over to our ambulance, and then log roll them just like we do in the ER. The backboard does not do any benefit for the patient, but they are good for moving them. We stopped doing this in some of my communities. It's been many years back now. Now it's just commonplace. If somebody's on a backboard, even the trauma surgeon, why is this guy on a backboard? What's the deal? But man, back when we started this, I had trauma surgeons tell me I was going to lose my medical license for not putting these patients on backboards. But fortunately, we've moved that needle a long way.
Hey, Dr. Troutman.
Yes.
This is Jane. Yeah, unfortunately, the curriculum has not changed yet. I mean, other than that they're not actually testing it as one of the random basic skills, but it has not been entirely removed from the curriculums yet, and there are still test questions on it. We still have to teach it. It is being phased out, but it is still in the actual curriculum for a while longer, I believe.
Excellent. Good to know. So, you know, and like I said, there is a benefit of understanding how and when to use the backboard. But what I'm hoping, and, you know, sometimes there are things that you have to learn to take standardized testing, and there really is the cutting edge piece of whatever it is you're testing on, in this case, pre-hospital medicine. But, you know, how to backboard somebody is probably a skill to know, but generally we should not be backboarding everyone we see this.
Correct, and I think that's where we're going with it. I mean, even in our curriculum that we have, there's a lot of emphasis on spinal clearance. And, you know, and again, like you said, teaching how to do it if the situation arises, which is 1 in a million, but that you can do it correctly, but it has not been removed as far as that goes as teaching it. In fact, on the Appendix G, which whatever we're calling it now, it is still a requirement even from COAMPS for accreditation in the original first days of skills for paramedic, where you go through in your EVAMP and you have to go through all the basic skills. Spinal immobilization seated and spinal immobilization supine are still required for us to verify because of our accreditation.
Awesome. Good to know. I think I'll stop here. I've got some more slides, but I know we're getting real close on time. But, you know, these are just a few pictures of, I mean, I could talk so much about why I just love EMS. This top right and bottom left was actually in Tijuana, Mexico. We were at an EMS conference in San Diego, and these other folks with me were some other EMS medical directors around the state, and we went over there for the day. And of course, we're like, we got to go see an ambulance. So we went to the Bomberos, and they gave, and I probably butchered that name, I do not speak Spanish, but they were very inviting. They gave us some shirts with their logos and all those great things. And that bottom right picture, those are some other Texas EMS medical directors. I was fortunate to get to work the Super Bowl in Houston when it was here. What was that been? Probably 3 or 4 years ago now. So that was a really cool experience. So if anybody has any other questions?
Dr. Troutman,
feel free
Bria
to pop up.
Gallegos asks, so if they're walking after an accident, but they have neck pain, can a collar be enough after you've checked C-spine, of course, and they have good CSM?
Yes. In my protocol, yes. And that should generally be the standard of care for pre-hospital medicine. Essentially, oh man, you're going to test me now. I'm not cheating. Look at the protocol. But so if you're neurologically intact, you're not altered from alcohol or some sort of drug or from a head injury. If you have no neck pain or tenderness, if you don't have a distracting injury, if all those are intact, then we can essentially clear them in the field. If they fail any of those, then we can consider placing just a collar, and then what we like to call spinal motion restriction. So these are patients, so let's go back to that patient let's say they're just 20 foot out into a field, and it's like, well, they have a lot of neck tenderness and I can see their distal tibias hanging out their foot. Somebody give me a collar. Actually, let's not do the tibia. Let's say that their distal wrist is open. It's an obvious fracture. Somebody go give me a collar and come with me, ma'am. I'm going to walk you to the ambulance. That is not the answer. You should still bring the cot to them, lay them on the cot, and essentially strap them down to the cot. Use the cot as essentially a backboard, if you will. These patients, until we definitively know if they failed one of those criteria, so we definitively know with imaging and stuff, they shouldn't really be moving around on their own power. Although I will say, so somebody brought up distracting injury seems fuzzy. That is absolutely true. So a distracting injury is not super well defined. We take, because some people will say, well, there was a pretty good scratch on their arm. Is that a distracting injury? I would tend to argue, no, it's probably not. I personally like to think a distracting injury is a pretty obvious fracture, or it's one thing if your arm's filleted open and you can see their bicep every time, and it's like, oh wow, that's kind of cool. That is probably a distracting injury, but it was defined fuzzy, if you will, in the nexus criteria that came out of Canada, which is a lot of this has been born from. So I'm reading what some people are writing. Yeah, somebody's talking about they use a collar and then tape their heads to the stretcher. Again, that may be some of the right answer on how to technically backboard somebody, but as far as for me, if they had a distracting injury or had a neurological deficit or what have you, place a collar, lay them on the stretcher, put your shoulder straps, strap them down, and that's it. That's really all we need to do. All right, any other questions?
In regards to CPAP, what is the difference between CPAP and BiPAP? Because I know sometimes when you take a patient off of BiPAP and try to put them on CPAP, they don't oxygenate as well.
Right, so BiPAP has got essentially two. It's got an in and an out pressure. So oftentimes when you hear a BiPAP, you'll hear 10 and 5 is probably the most common, or maybe a little higher than that. So you have a positive pressure in inhalation and exhalation. Where CPAP is just a continuous positive pressure. There are probably times generally when BiPAP, if I could always do it, BiPAP is probably the better option. The issue is generally BiPAP needs essentially oh my gosh, I'm blanking. CPAP I can just hook up to the oxygen port in the ambulance, so it's cheap to use. BiPAP needs somebody help me here, I'm totally blanking. The same thing, you'd have to hook up a ventilator. BiPAP generally has to have a ventilator, which can have a significant cost to a service. I mean, on the cheap side, it may be several thousands of dollars. Now, there are that kind of geared just to BiPAP, but still, it's yet another device. It's another thing to learn how to use, versus we buy these CPAP things from, I think, Boundtree, that's like 30, 40 bucks that you just plug in the oxygen, you turn on, and you can adjust the settings a little bit on those. So hopefully that answers that question. So yes, BiPAP, if I could always have BiPAP on every truck, that would be a better preference to CPAP, but it's a limitation on that. Any other questions?
With the using just a non-rebreather for CPR, just to have oxygen on the patient instead of putting in a tube or anything, why would you just go ahead and put the non-rebreather or whatever on the patient instead of trying to set an eye gel first or anything else like that? I understand compressions are necessary and you're going to want them, but just, I don't understand the just having the non-rebreather or whatever
Yeah.
you have to have.
So I think it's a great question. So again, what we find that really the two things that matter are those compressions and defib. And even if we tell everyone that, like, hey, that's the only focus, but you know what, go ahead and get the eye gel. Hands down, people end up focusing on that airway. We've seen that happen for a number of years in EMS. People just want to get that airway established. We have always felt like that's paramount. I even see that now in our ERs. And I like to say, I think when it comes to cardiac arrest, y'all perform the best cardiac arrest care versus even our biggest, baddest hospitals. I have watched more than one physician colleague mucking around with an airway when they should be focusing on what really matters. We've also found that, you just having the oxygen on the face and the chest compression, we are bellowing the chest. We are getting oxygen in. We're getting enough oxygen in. Sure, we're not getting as much if we had a fully established airway as an endotracheal intubation would, but it appears we're giving enough, and the science has not shown that it's been problematic either. I know the AHA and their most recent guidelines, this is not, if you take the AHA course, this is not an ACLS thing, but it is, there's several paragraphs that discuss this that more or less says, yeah, we think this is okay. They just haven't bit off on it as making it the ACLS standard. I think it will be, it's coming. I hope that answered it.
Yeah, having recently taken ACLS, the emphasis on epi as compared to the way you just presented it is quite a contrast.
Yeah, there's still a lot of people that feel like epi is like this savior thing, but look at the big good EMS systems, and that is not the general consensus. I think a number of us just want to stop using epi, but that just seems such a contraindication from these standards out there that nobody's been willing to do that. And there's a number of us that have done these epi infusion situations, and we haven't really seen our ROSC change. So it's not necessarily going to make it better, but it doesn't make it worse. But again, it does put our crews back over focus on what they need to be focused on.
Wow, this was a great group tonight. Really enjoyed this one. Anybody else got anything else for Dr. Troutman?